Well, hello there. Welcome to Wilkes Wednesday webinars. For those of you who may be joining us for the first time, I'm Margaret Steele, Chief Development Officer at Wilkes, which means I'm responsible for alumni engagement, university fundraising, and the respective stewardship of those relationships and the donations. Our seminar schedule and our past recorded videos are available for your viewing on the Wilkes Alumni Association webpage. You know, we are so very fortunate as an institution of higher learning to be able to draw on reliable and evidence-based expertise from alumni, from our faculty and staff, and even from our student body as we learn and grow together. Today's webinar focuses on science, specifically virology and the public health implications of the novel coronavirus. We certainly are grateful for our two alumni volunteers who have stepped forward to help us all understand this complicated topic. We hope each of you will continue to stay engaged with Wilkes as well. There are many volunteer opportunities. We also hope you will consider our efforts to support our student needs through our General Scholarship Fund, our First Gen Fund, or our Unrestricted Wilkes Fund, which supports our university's greatest needs. And this year, it certainly includes emergency assistance. Now, if you want to give and receive, you may have noted the opportunity to make a donation and receive a special Wilkes branded mask. Perhaps our speakers will address the benefits of mask wearing, or you may note it also doubles as a neck warmer or a pretty nifty headband. So perhaps long after this threat has passed, it will serve as a memory of our Wilkes resolve and our Colonel spirit. So let's get this webinar started. Mary Simmons is our Associate Director of Alumni Relations. In addition to holding responsibilities for our alumni engagement activities, including coordinating relationships between alumni and students, she is also helping our Wilkes community to stay virtually connected in unique ways. Mary will facilitate our webinar today. Mary?
Hi. As Margaret mentioned, I will be facilitating the webinar today. And I just have a couple of notes before we begin. All participants are in watch mode, but we do have the capability to be interactive. Please use the Q&A button at the bottom of your screen if you have a question at any time for our presenters. Those will be answered as we go along. If you would like to comment to panelists and other participants, please use the chat box. And in fact, we encourage that. So if you'd like to drop your name, class year, maybe where you're from, we could see who is all here today. I would like to begin by introducing our presenters. Ruth McDermott-Levy is an associate professor for the Center of Global and Public Health at Villanova University. She teaches global and public health courses at the undergraduate and graduate levels. Ruth is an experienced community health nurse with 15 years of delivering nursing care in urban communities. This academic year, she developed and taught an online climate and health course with students from Villanova, the University of Port Harcourt in Nigeria, and the University of Eastern Finland. Her expertise is in the impacts of climate change upon the health of vulnerable populations, and she is a skilled researcher using qualitative and needs assessment methods. Ruth has also conducted research of the health of immigrant and refugee populations, Nicaraguan community health workers, and fracking communities. In 2018, Ruth spent the fall semester in Finland as a Fulbright scholar, teaching community and environmental health and studying the health impacts of climate change in Finland. Ruth has published in the public health nursing literature and textbook chapters. She is an active member of the Alliance of Nurses for Healthy Environments, Columbia University's Global Consortium of Climate and Health Education, and is the only nurse on Pennsylvania's One Health Committee. Chris Woolverton is Professor of Epidemiology and Dean's Fellow in the College of Public Health at Kent State University. He has been at Kent State for about 25 years. After Wilkes, Chris received his graduate training in medical microbiology from West Virginia University School of Medicine and postdoctoral training in immunology from UNC Chapel Hill. Among other universities, he has received additional training in immunology, biological safety, biosecurity, biorisk management, and policy analysis from MIT. Chris recently was awarded a 2020 Jefferson Science Fellowship through the National Academies of Science, Engineering, and Medicine. He is a contributor to numerous publications and abstracts and serves as an ad hoc reviewer for microbiology-related journals and funding agencies. He has 9 issued patents and is the co-author of the undergraduate textbook, Prescott's Microbiology. He has served on the City of Kent Board of Health since 2005. As our presenters come on, you will see some poll questions running on your screen. So when those appear throughout the presentation, please answer them and we will share results. Ruth and Chris, take it away.
I wanted to make sure that Margaret saw that we indeed were wearing masks to protect ourselves. But wait, there's no need because there's nobody else in the room with me right now. But I wanted to thank both Margaret and Mary for the opportunity to come back and share with Wilkes. Back in that day, it was Wilkes College for me and Ruth. And it's been a wonderful opportunity. It's really launched my career in ways that I can't even begin to explain. But I know Ruth is in there too. Ruth, you want to join us? And we can begin our presentation. We're going to kind of play round robin here. And Ruth and I will share some slides just to kind of make sure we're all talking the same language. And then please, as Mary indicated and Margaret indicated, feel free to ask questions, and we'll certainly have time at the end if you have additional questions. So if I could have the first slide, please. The wonders of modern technologies. Next slide, please. So in the field of epidemiology, we practice a very specific science-based, evidence-based process. And that in the field of infectious disease epidemiology includes what's often referred to as the epidemiological triangle or the epidemiological triad. And here we have for you just a quick two-dimensional version of this to show you how we process information, especially in light of a very new or re-emerging infectious agent. You can see the triangle is based primarily in looking at the relationships between a host, the microorganism called the agent, and the environment in which both of those reside. You can map almost any infectious disease in this mechanism. And oftentimes in the very center is where I add a piece called biosafety. And I've been training and studying and teaching this area for about 20 years now. And the whole goal there is, how does the host protect itself from the microbe and the environment? How does the environment protect itself from the host and the agent? And how does the microbe, is not as smart as it should be, protects itself from the host and the environment? So it's this really unique balance and interaction that allows for a very nice One Health system for planet Earth. The problem is it doesn't stay balanced. And as you see to the right there, oftentimes the microorganism is in a struggle with the host being the human, us, and it kind of skirts the environmental issues because now the environment becomes the host and the host the environment. And under those conditions, you're really looking at a situation where a dynamic relationship is going back and forth, one in which the microbe is trying to get to the host because it wants the host as its nutrients, as its other warmth and other products by which it can survive. And the host is really trying to defend itself against a microbe that would want to exploit its resources. And so this becomes kind of a balancing act. And as you will see as we progress through here, as the SARS-CoV-2 agent erupted several months ago, it gained access to a host as it left its relatively quiet environment that we imagine was the forested area in China near Wuhan. And in that environment, it was very happy and content to hang out with what we perceived to be was its natural host, some type of fruit bat. What happened though, as the population got closer and closer to that forested area and the bats got more and more spooked, they tended to leave the trees and came more closely in contact with the humans. At that point, while we don't know the exact mechanism by which the virus left the bat and got into the human, it happened. And it probably happened several times. In fact, some of the data we have for a number of different coronaviruses demonstrates that over the many years prior to 2019, there were a number of exposures of coronaviruses of this type in Chinese people. And by measuring antibodies and studying the antibody response in them, we're able to make that fact known. You have the next slide, please. So we want to talk a little bit more about this virus and try and get a handle on what it is and what it's not. We use the word novel whenever any virus, or bacteria for that matter, is brand new on planet Earth. So here we have a coronavirus. It was a bat exclusive virus, and somehow it jumped species into a human. So it's novel in humans. And if you look at the epidemiology, what we're starting to understand here, even though we have a lot more learning to do, is that the virus left its normal area in the bats, got into a human, and then another mutation occurred that allowed for human to human transmission. And that was a critical event that happened. For some of you who are wondering why we call it a coronavirus, the word corona is in reference to the halo that it makes on electron microscopy. So here is a picture from the CDC website demonstrating that when you look at this particular type of virus, its spikes form this kind of halo around the individual virions. And as a result, the name was conferred upon it as a coronavirus. This particular virus, we believe, started to erupt out of the bat colony and into the humans in late November of 2019. Certainly, there are enough data to demonstrate that it has been migrating and slightly mutating as it's entered into the human population. The virus is about 99% similar to the coronavirus that erupted in 2003. That was the first SARS virus. And many of you may remember that how it erupted, left China, went to Hong Kong, and from Hong Kong all over the world. And it actually caused quite a few fatalities. But this is what scared us initially. The virus was very similar to that one. We're not quite seeing the level of fatality that the 2003 coronavirus caused, but we still have our ears up looking to make sure and listening to make sure that it doesn't change into something else. As I indicated, the person-to-person spread is now possible. We talk about the two different types of respiratory spread that's known as droplet and airborne infection. Droplet refers to the fact that when you cough, sneeze, or even talk, the mucus and saliva in your mouth and upper respiratory tract coat the viral particles, and they exit your upper respiratory tract a little larger, somewhere between 10 and 500 nanometers. And as a result, they're really quite big to get inside of another person's respiratory tract. So you can imagine like a projectile, it leaves your mouth, your respiratory tract, and it lands on a surface, and you happen to touch the surface, or a person near you touches the surface, and then you do what I like to call auto-infect. You touch your mouth, you touch your nose, you touch your eyes, and those mucous membranes are able to attract and attach that virus particle, which then gains access to your upper respiratory tract. The virus can also, as it leaves your mouth and your upper respiratory tract and follows a trajectory in that direction, has to also deal with one additional force, and that force is gravity. And as gravity pulls it downward and it's moving forward, evaporation occurs. And when it evaporates, it becomes smaller and smaller and smaller because all the mucus and saliva is what's leaving. And you end up with a much smaller particle, something less than 5 microns, which is very easily for you to inhale as you walk past it. And so that's why right now we're still trying to figure out, is it truly just droplet, or are there also aerosolized particles that are infectious? And the data are not 100% clear, but we're leaning towards yes, it's both. There's also been evidence in the literature that it can be spread through feces, because one of the symptomologies is for diarrhea to occur. And in that case, a lot of viral particles are shed through the feces. And it's also true that there was a paper recently that documented it can be housed in the seminal vesicles and thus depart the body through the semen. And whether or not that's infectious is yet to be determined, but it's just worth a note. Over the history of our studying of coronaviruses, there are about 500 different coronaviruses on planet Earth. 490 of those plus are bat viruses. 6 of those coronaviruses are human coronaviruses. 4 of them are very, very mild in humans. They cause things like the common cold. There are 2 rare, highly fatal coronaviruses. I already mentioned the original SARS from 2003, and there's also the MERS, the Middle Eastern Respiratory Syndrome virus from 2015. And so taken together, we recognize that this is a very interesting class of viruses, and that it's certainly right now in dealing with the novel coronavirus that we're now going to call we're going to call the SARS-CoV-2. That's the name of the virus. And the disease that it causes, we call COVID-19. Next slide, please. So I just wanted to not sure what happened to that slide, but show a picture, a close-up of what the virus looks like. And the important point for this slide is to indicate those spikes that are sticking out. Those spikes are the proteins that stick to the receptors on our upper respiratory tract cells. That's how the union of virus plus cell occurs. And as a result, that's the protein that we look at when we're trying to make a vaccine, or when we're trying to determine if there's a mutation that's taken place, which might cause an additional reaction by this virus. Next slide. So as I mentioned, we call the virus SARS-CoV-2, definitely a respiratory virus, shed by humans who are infected by coughing, sneezing, talking, laughing, and quite, believe it or not, even singing. There has been evidence in the literature now of a choir practice in Washington State where 45 people were infected by one person who was singing nearby. There's also this big concern of what's known as asymptomatic transmission. This is the case where an individual has no symptoms of having the disease, but they are in fact able to shed the virus. So it's multiplying in them, and when they talk, sneeze, laugh, maybe even sing, they're releasing the virus into their environment. And as a result, no one knows to stay away from them because they don't know that they're infectious. So this is a big, big concern for us in epidemiology, and we're very concerned on what this means in terms of dealing with the second and third wave of infectious disease that might occur if we don't get a handle on this very quickly. Best estimates demonstrate that it's somewhere between 25 and maybe even 30% of the infections that are out and about around the globe. I'm going to go ahead and ask for the next slide. So one of the things that I wanted to also make clear as we think through the virology here is that a virus is not a living organism. It's a piece of nucleic acid, in this case RNA, captured inside of a protein coat, and in some cases surrounded by a lipid membrane covered in proteins. In this particular type of virus, as in HIV and hepatitis B viruses, the membrane that surrounds the virus is actually stolen as the virus leaves the host cell in which it replicated. So that virus is stealing the lipid membrane, and it has programmed the host cell to make the proteins that go to the lipid membrane. and are waiting there for the virus to steal the membrane. So it serves twofold. One, that lipid membrane protects that protein capsule holding the nucleic acid from dehydrating to some degree, but it also protects it from the elements outside of its normal host cell. And the second thing is those spike proteins allow it to infect the next cell. And so it's kind of setting its own stage so that it's able to gain access to the new host. I wanted to point out though here that as we think about going forward, how do we create therapeutic agents that would destroy this virus? One of those things is targeting the nucleic acid. Very similar to what was done with HIV in the early days, is to target the replicative process of the nucleic acid, or to out and out just destroy its ability to be integrated into a bigger protein, to be translated into a protein. That's for chemotherapeutics. In terms of vaccine production, as I mentioned earlier, we really want to focus on those spike proteins and find the exact spot on the spike protein that interacts with most human cells, and then we'll create our vaccine against that particular protein. And then lastly, the lipid membrane is basically the Achilles heel of this type of virus. Remember lipids, if you go back to your basic biology, oh my gosh, all the way back to 7th grade maybe, where we took red blood cells and we mixed them in water and we watched them explode. And if we mixed them in water that had soap in it, dish detergent in particular, we watched them explode even faster. And that whole concept has to do with lipid membranes. And that if we can disrupt and break the lipid membrane, the cell falls apart. Well, that was the red blood cell. Here, if we are able to break down or dehydrate that lipid membrane around the virus is no longer infectious. It cannot get inside of a new host cell. So this is why we're being so fanatical about hand washing and about cleaning surfaces, because we know that we can really do a good job destroying the virus with a little bit of soap and water, and certainly with much more caustic types of chemicals like bleach. Next slide, please. So if you see the information that's coming at us in almost lightning speed, this was May 10th. So this was Sunday afternoon. I downloaded this information from the CNN website where they collect their data from the Johns Hopkins University's Department of Epidemiology. You can see the number of cases globally. We're up over 4 million cases now. And sadly, we're up over 280,000 deaths as a result. This has come back to a conversation that we'll have later. I think if Ruth doesn't cover it, I'll come back and discuss, is what we often refer to as the case fatality rate. And right now, it's an open door. Because this virus is doing different things in different aged people and is killing people in some parts of the world differently than it is in others, a final case fatality rate has not been able to be determined. So we can talk about a particular age group, and if you talk about the elderly in particular, in some parts of the world, we're seeing case fatality rates upwards of 15 to 20%. That's pretty scary. But if you look at other parts of the world and you look at 1-year-old to 15-year-olds, we see case fatality rates that are below 1. So if you average those out, you're going to get something much, much lower, especially as we collect the data coming out of other countries. So it's something that we're keeping a very close eye on. If you look at the United States, that's the biggest bubble, if you will. And if you look down at the legend on the bottom left of the slide, you can see how an indication of total number of cases is reflected by the size of the bubble around the country. Next slide, please. So we zoom in on the United States, same data set. And you see the biggest bubble is mostly around New York State, but certainly around most of the northeastern United States. About over 1.3 million cases so far in the US, with close to 79,000 deaths. Again, you can't just put the one number over top the other and say this is the case fatality rate, because as I mentioned earlier, it's different in different parts of the country and it's different for different age groups. But I wanted to show this to you as we begin to think about where are the hot spots And importantly, as we look at the progression of the disease from both the West Coast to the middle, from the East Coast to the middle, what we see as the next emerging hotspots are those middle states of the United States. When you start talking about Chicago and Des Moines and some of those other, Detroit in particular is erupting really widely. So as you look at that, that's where we see progression of the disease moving even now. And that's with all of the states that have had so-called lockdown discussions and shutdowns of their state and activities. As we reopen the states and allow for more and more business opportunities to interact as they were before the virus, and we're really concerned that we're going to see these bubbles get even bigger as people who weren't infected yet will become infected if they're not careful. Next slide, please. So this is that slide that helps us look at some of the other countries, right? So we talk about flattening the curve. You hear that phrase on the news, you hear it just about anywhere where people are talking about COVID-19 disease. So this is what we mean by that. As you look at the incline, the number of cases of COVID-19 that are recorded, you start to generate a curve with respect to time. And for those countries that were able, because of their type of government, to shut everything down and lock people away, here you can see, for example, China, mainland China, look how flat their curve is. And you can see South Korea, very similar in terms of their ability to shut things down. But now as you look at Singapore, you look at the United Kingdom, you look at the United States, what is quite clear is that those curves are definitely not flat. In fact, if you draw an extension of that graph back to the axis on the far left, what you can calculate is a rate of increase. So how fast is that curve actually ascending, and how far will it go if it isn't flattened? And so this is a really important piece of epidemiological data that we use to try and understand what the progression of the disease is and how much effort we have to add to the system to get it to flatten the curve. Next slide, please. So as I mentioned, well, actually, as Mary mentioned for me early on, for the last 15 or 20 years, I've focused a lot of my career in the area of what's known as biorisk management, which includes the study of biological safety and biological security. And clearly, one of the things that we're careful to make sure we help the world understand is that in the face of a national emergency, when emergency response operations have been activated, that very clear sequence of events has to happen in order to educate the masses, help people understand what the problem is, and help them prepare to deal with the problem on an individual level. And so we talk about communication, and risk communication or emergency response communication has to be accurate, truthful, and transparent. And without talking politics, I think it's important that we all realize this is extremely important at any level of government and even within your own household. Because if you want to be recognized as someone who has a valid point of view, you want to be accurate, truthful, and transparent. We also want to be able to teach the individual and the family what we call preparedness practices. So being able to make a communication plan so you all know where you are at any given point when an emergency erupts, that you all have a common meeting place to arrive at when that emergency erupts, and that you have squirreled away a small amount of food, water, and emergency supplies. We call that the emergency kit or the shelter-in-place kit, and that's the bottom line there, so that you're able to get through the emergency without having to worry, oh gosh, I didn't get to the store, I don't have enough toilet paper. Well, you would have put a couple of rolls into your get-home bag just in case you needed them. The last part of this really talks to and speaks to your understanding, our understanding of what everybody else is doing around us, because we're not the only ones that has an emergency response plan. Our cities have them, our local governments, our health departments, and even our local schools, places of worship. Everybody's got their own version of an emergency response plan. And if ours is contrary to theirs, we're going to have problems. So if you have children in elementary school, you want to know what their plan is, because if you show up and they're in lockdown, they're not going to let the kid out, and you're going to be standing outside begging. It's just not going to happen. So you want to get on the same page with what their plan is and your plan. Next slide, please. And then lastly, before we jump into what I want to hear Ruth say, I want to set the stage for her because she's going to talk a little bit more about the disease and the rest of the epidemiology. And so this is a slide that I actually stole from a medical group called Sanford, but they stole it from the CDC, so it's fair game to use. Right? And I added one additional symptom that is not yet on most of the infographics that have been placed out in public domain. And that's this top neurological syndrome, which has now been well documented and placed in the literature, where people are losing their ability to taste and smell for a couple of days and otherwise having mild COVID-19 symptoms. So that seems to be the predominant symptom. They might have a little bit of diarrhea, they might have a little bit of fever, but that tends to be the predominant symptom, not being able to smell or taste the wonderful meal that their significant other just prepared. Right? Now, you've all heard of these others, and I mentioned some briefly. And what becomes the real issue here is the elevation of fever and the consequence of the inability to successfully transfer oxygen from the air into your bloodstream. And that becomes a real issue if you want to stay alive. Ruth?
Thank you, Chris. Mary, if we can move to the next slide. But before we go forward, I am a nurse, and I feel this is actually, yesterday was International Nurses Day and Florence Nightingale's 200th birthday. So I really need to give a shout out to Wilkes nurses, yay, and especially the Wilkes nurses that are on the front line and those who will be graduating on Saturday headed to the front line. So thank you all for your amazing work and intelligence in this. Mary, are you able to move to the next slide? So what I was tasked to do is to talk about the epidemiology through the human. And I laid that out using the epidemiological triad as far as what Chris explained, but also kind of the timeline of events, because basically we are seeing a public health crisis unfold on CNN or whatever news station you watch. And so we're all seeing it in real time. The first thing I also want to say is public health, just explain what public health is. You've probably all heard about it, but a lot of people are like, what is that? So it is a discipline that includes many people from various disciplines. Chris is in microbiology, I'm in nursing, we have people in policy, people in engineering doing public health. But public health is about prevention of disease and its consequences among populations. And so I'm not going to be talking about the detail really of what it is to be sick with COVID-19 a whole lot, but more how does that play out on a population, specifically in the United States. So early on, what we saw was direction from the CDC. And if you'll see, CDC, if you'll watch carefully, and I hope you are, CDC is still trying to figure things out too, because as Chris said, the science is evolving. So we're seeing things change as we learn more, and because this is a new disease in humans. So early on, the CDC said the symptoms of COVID-19, the disease caused by the novel coronavirus, were fever, cough, and then more extreme symptoms were shortness of breath. So next slide, please, Mary. And so I'm also sharing with you the discussion that I had with my colleagues at Villanova of how do we prepare for this? How do we address our students that are going out into clinical settings? How do we address our partners? Because we have community partners internationally and in the United States. How can we meet their needs as things were shutting down? And so the first thing we talked about was who is at risk? Who do we need to identify and who can we reach out to? And our initial conversations were the typical players that you always think about of who is at risk of the disease. So certainly the elderly or older adults. And if you're 65 or or in that range. You're not elderly, you're just an older adult. I'm getting closer to that, being in the class of 82. But as we age, we have more pre-existing health conditions known as comorbidities. We have, and our immune system becomes not as strong. So naturally they're at risk of an infectious disease. And then we talked about patients or groups of people that may have respiratory disease and cardiovascular disease, and people who are immunocompromised, who have some sort of condition that would make their immune system not as strong, or on medications that would make their immune system not as strong, such as somebody getting cancer treatments. So they were the first group of people that we talked about, who we needed to target. As things moved on with this disease and we learned more, we found out not only were that group at risk, but specifics of cardiovascular disease, such as somebody with hypertension, somebody with diabetes. And then they added in people who were obese, people with chronic kidney disease or renal disease, and then people with liver disease. Also in our conversation, because Villanova is borders are very close to Philadelphia, so and some other communities that were very low income communities. In fact, Chester is in Pennsylvania is the one of the poorest communities of the state, and we're in the same county as Chester. So those partners that we had in those communities, how could we address their needs? So low income people are also at risk for many pre-existing conditions. They have limited access to healthcare. They have limited access to healthy food often, and they often tend to be people of color or what's known as minority groups. So Latino populations or we have some people from Southeast Asia and Philadelphia. So we have a variety of immigrant populations that we need to address. And then the other thing is we serve the homeless. We have some partnerships with those people that serve the homeless. So how do we help them when they don't have access to running water? So these populations are also the same groups that are coming up in the bigger discussion if you're listening to the news or reading the news. Lastly, we talked about congregate living. Certainly we thought of nursing homes right away. We did talk about prisons because we have a relationship with one of the prisons at our university. So that population is going to be at risk. I'm in a Catholic university. We have a monastery. So we've got a bunch of older priests living in congregate housing. We've got students on campus living in dormitories. Now across the United States, we've got everybody's home and we're all online right now. But what does that mean as we start coming back to campus? So these are, this group housing is a real concern, and we are seeing, we certainly are seeing in a long-term care, in convents, there's been some outbreaks. There's been certainly in prison. So what does that mean now, and how do we protect people and reduce transmission? And as a university, what does that mean when we return? Because that's a big concern. Mary, next slide, please. So as we move through this timeline of the unfolding of COVID-19, as Chris said, we wanted to look at, or one of the ways we identify the risk of a disease is case fatality. And how we determine what a case is by testing. And so we need to have accurate testing and test as many people as we can to determine indeed what is the case. And early on, we've had some problems with testing. Some of that has been resolved, but truly we do not have enough testing. This actually is a photograph of a friend of mine, Shelley Hickey, who's doing drive-by testing. And so we can't determine how many cases we have to get that case fatality rate. And for those of you who don't do epidemiology, what case fatality rate is? The number of cases, the number of deaths divided, the number of cases divided by the number of deaths. Deaths is on the top and your denominator is the cases. So that's how you get the percentage of the impact of this disease. So what we're looking at with that is, how is this agent being transmitted across the population? Next slide, please, Mary. So on March 16th, if you remember on the news, the president and the team came on and said that we need to stop the spread of disease. We need to have, we need to shelter in place, essentially. We need to stop social gatherings. We need to limit travel, only necessary travel, and to prevent the flow of the disease. This is March 16th. I think today's May 13th. At that time, they said, give it 2 weeks, right? And we're all like, okay. So here we are still sitting. This is also how we're still learning about this disease and learning about host behavior. Because one of the issues is that this disease does come into us and spread, you know, and then we can spread it, but it also depends on us. So there's behavioral factors that we need to participate in. And we're seeing how that is or is not working in certain areas. And that there's other issues as well that we'll get into. So next slide, Mary. And the way they came up with the 14 days of just stay put is, it is known as the incubation period. So it's the time of exposure to the agent, so exposure to the virus until you start to have symptoms. 95% of the people who are going to get ill from this virus will do it within the first 14 days. So that's how they had that number. Typically, though, we start to see symptoms around 2 and 5 days. You start to see illness. But, you know, just to be sure, people stay home 14 days. This is known as quarantine, because those of you who are staying home who don't have exposure and are just staying home to be good citizens, thank you, but you're not quarantined. Quarantine is when there's exposure and you're staying at home to find out if you're going to get sick. So we are seeing people now who are being quarantined. Dr. Fauci is self-quarantining because he was exposed to somebody in the White House who was tested positive. So that it just drives me crazy in the news when they use the term wrong. So next slide, Mary, please. So the next day, so this is how quickly things are unfolding. That's why I did this timeline. The next day, we realized, or the healthcare profession was screaming, they don't have enough PPE, because people were, prior to early March, people were being hospitalized around the area, and certainly in Philadelphia in our ICUs, we had COVID positive people, or COVID-19 people that were in ICU beds. And so the healthcare profession was recognizing and calling out that there was not enough PPE. And the reason I have this bolded is, this is a group that's also at risk. Of course, we always think healthcare providers are at risk, but if they have enough PPE, I'm somebody who worked during early HIV, and you know, we learned how to protect ourselves. But and the staff now knows how to protect themselves. They just didn't have the right equipment, and so we needed to add them to a group that is at higher risk than we ordinarily would have thought of. We also learned that we needed to add essential personnel to the list of people at risk. When we think about the essential personnel, when we think about who is doing the work for us so that we can stay home, these are our mail carriers, our grocery store workers, the farmers, the meat packers that we've been hearing about, and the inspectors, our trash haulers. We would be in really big trouble if we didn't have our trash removed away. That would be another public health problem. And so all of these people are doing work so that we can be safe. But many of these are low-wage jobs. Many of these are staffed by people of color or immigrant populations. And so these are people that we're starting to see in some of the data that we're going to look at in a little bit. Next slide, Mary, please. So the next day, we come, I mean, at the end of March, it was probably very stressful for everybody, but it was one thing after the other. The next thing we learned, and Chris said this is not a living thing, but it does remain stable on surfaces. And we found a variety of surfaces that virus remains stable on. And so this looks at the environment of that agent and how do we manipulate the environment. And again, that's behavior of the host. What is the host going to do to manipulate that? And that comes down to keeping the surfaces clean that Chris said. Now, I don't want to put a timer on my doorknobs. In 4 hours, it's safe to touch. Or, you know, looking at wood, I can touch that in 10 days if I think it's been exposed. So really, if just frequent cleaning of surfaces is the way to do this, coupled with really good hand washing, and you can prevent risk. And then also not having a lot of people come in your home, you know, really trying to do the best to separate can be very helpful for preventing the agent to be on surfaces. Next slide, please, Mary. So initially, again, we said that the older people, and we were hearing that from China, that it was, and Italy, it was primarily the elderly there, or older adults that were at risk. But the following day, we find out that it's all ages that were at risk. And the CDC issued a report that 1 in 5 hospitalized cases were young adults between 22 and 44. We also just very recently learned, I'm sure you've all heard about the pediatric multisystem inflammatory syndrome that looks like it might be related to the SARS, the novel coronavirus. So the patients either tested positive for the virus or they had antibodies. And again, this requires a lot more investigation. We are watching real-time unfolding of an infectious disease, and in a way that we never have before, mainly because of the media, and it's a good and a bad thing, but I think it's good for us to be informed. And so this is something for us to keep an eye on. And certainly now considering, you know, what does that mean then for return to school for children? You know, those of you who are parents and have been homeschooling your children, God bless you. I'm sure that's very challenging, but what does that mean for children to return to school? How can we keep them safe? And all the things that kids do that really probably are not the best things for infection control. Next slide, Mary. So then a couple weeks later, we hear that the CDC does recommend that everyone wear a face mask in public. And early on, they were saying that it wasn't necessary, and now they're saying it is again. So we're watching that as they're learning, they're sharing more with us to protect the public. At this point, they're saying a cloth face mask. And so, you know, there's different levels of face masks. There's a cloth, there's the surgical face mask that looks more like paper, and then the N95 that is really for healthcare providers or people working in labs that are going to be exposed to the virus that's going to aerosolize. And so, you know, things will be considered as we move forward, and what is the safest for the population. Really what the cloth face mask does is prevent the larger droplet spread. And if I wear one and suppose Chris wears one, it prevents that spread between each other. It does not do a really good job if somebody is in a high intensity area. Next slide. So then we had more symptoms added. So remember I said early on it was fever, chills, and then shortness of breath for severe disease. So that was in mid-March. By the end of April, they added the chills, muscle pain, headache, which sometimes people just present with just a headache, or they, you know, so they may present with just one symptom or many symptoms. And as Chris said, the loss of taste and smell. I remember early on that coming up, and Dr. Fauci kind of dismissed it because really, if you have a cold, your sinuses can be congested, and you may not smell or taste things appropriately. But now, again, with more evidence and studying it more, they have added that. But if you look at some of these symptoms also, they could be, you know, I get headaches from being on the computer all day long. Or a couple of weeks ago, I was having a sore throat because of all the pollen in the area and allergies. So we really want to stop and think, because at first I kept getting the sore throat, oh no. But then I'm like, wait, I haven't been anywhere. So of course I don't have the disease. So it is really easy to get caught up in the anxiety of this. But, you know, just stop and think and think of where you've been. But certainly if you do think you've been exposed, talk to your healthcare provider. Additionally to this list, more recently, I think in the last week or two, it's all starting to run together. we're seeing that young adults are at risk of strokes because this virus is causing clotting of the blood. So that would put one at risk of strokes. And then there's this phenomenon of COVID toes, which is rashes on the toes. It's a combination of that and or almost like it kind of looks like a what's it called, a frostbite, because they think it could be related to, again, clotting in the small vessels of the toes. So this is something that we need to watch and see if it plays out. And so I think what makes this virus so different from SARS and MERS is it seems to be more systemic, that it's affecting many, many organs and many systems. And so it's hard to diagnose or figure out, certainly without laboratory testing, but figure out what happens as we move forward with this disease and what is the outcome for the population. Next slide, Mary, please. So now we're to current times, and to get to the point of how do we reduce the transmission, because that's really what we need to do. Since we don't really have, right now, as far as treatment, we're treating symptoms. There are a couple drug studies in trials, and we've heard a variety of things of what is happening, but we don't have enough data right now to say this is the way to go with any particular drug, and we don't have a vaccine. So the way to stop it then is to reduce transmission, or to make it safer for people to go back to work. And so what is finally happening is what's known as contact tracing. Contact tracing is an old public health intervention for infectious diseases. And it was frequently used, and it still is used, for TB, where somebody has the disease and then they talk to all the people that came in contact with them. And that's what they're going to do now in regions of the country. You may have seen New York is starting to do that with Connecticut and I believe New Jersey. And then there's pockets that are happening around the country. And what it includes is you interview the person who tests positive and find out who they have been in contact with. Then you contact them and tell them to get tests and to remain in quarantine to be sure that they don't have the disease, and hopefully stop it. There's also what's been happening in other countries. South Korea did it. And we're also looking at it, I believe Spain did it as well, is using smartphone technology to see where groups congregate, to kind of track how people are moving. And that's different than contact tracing, but it does give us some information of what's happening as far as movement of people and thinking of outbreaks. So that's what's happening now. And the reason I kind of got a big smile, but totally frustrated over this, is this should have happened in the beginning. And they did a little bit of it on the West Coast. In New York State, I was listening to Governor Cuomo early March, and he said the horse was out of the barn, it was too late to do it. And now they're going back and doing it. And that was a moment I was yelling at the radio. My family had to put up with me going, no, you need to do it. And so now they're doing it. And also, those of you who are interested for this summer or looking for something to do, if you're retired, Johns Hopkins has a free contact tracing program. I actually started it. It's quite good. And so you can get certified to be a contact tracer and then support your community, and you can do it by phone from where you are. So it's a nice service thing for you to do if you're interested. Next slide, Mary. Oh my goodness, we're getting behind. Okay, so really quickly, we need to think about the impacts of once somebody's out of the hospital, it's not just the hospital care. And so we're seeing that of long-term impacts of this disease. Next slide, Mary. I'm going to zip along because, so what we're seeing with COVID-19 is the impact of chronic disease on the population, the health disparities that I mentioned of our low-income, minority, or diverse workforce, and then environmental implications, and then also our very fractured public health system of trying to put things together. The contact tracing is happening in the state level in some areas, and then some areas it's just pockets of different universities picking it up, and so that's a problem as far as communication. Next slide, please. I'm going to skip this and get to Chris and our discussion about the disparity. So Chris, I'm going to let you take this and then we both can talk.
Okay, Ruth, I was just trying to answer some of the questions that have been showing up in the Q&A box. We might want to have some time to do that as well. So one of the things that has become extremely apparent as we look at the impact of COVID-19 disease across the United States is those that are most susceptible to disease are not just elderly or a specific age group in particular, but they're a specific group of Americans that are oftentimes linked in with their community as a result of their economic status or of their racial or ethnic background. And what we're starting to really get a handle on is that those communities are actually clustering the disease. So we're beginning to see, as Ruth alluded to earlier, Philadelphia, for example, with its large immigrant population and population of peoples of color, that the number of COVID-19 cases is actually higher in those smaller communities than it is in the larger, more urban and more white communities. And so it's definitely exposing the class and race-based vulnerabilities that public health has been talking about for the last 35 or 40 years. So it's a function of community poverty, not just individual poverty. It's a function of polluted environments, not just an individual house that has lead in the paint. It's a function of higher rates of violence and incarceration, not just unemployment. So as we begin to put all this together, we recognize that if we're going to significantly cut this disease back, we have to recognize that the disparities that have been facing large groups of our citizens in the United States have to be addressed as well. And if it's one thing, like I said, public health has been pushing for a number of years, but now we need to make sure that everyone else sees it the way for what it is, that it's a detriment when a disease, a new disease in particular, shows up because they don't have access to the resources that other people do. Access to healthcare, for example, access to healthy foods, access to places with have less pollution. And so this becomes a real key for us. And when we start talking about higher rates of obesity and asthma and diabetes, it's predominantly in these populations who have poor access to healthcare. Ruth, your comments?
I can't agree more. And these, as you said, we have seen these before. I mean, these are all the things that we see in public health and the disparities within low income, primarily communities of color, and immigrant populations. And so if we're going to be a healthy nation, we need to make a decision. And I see this in that slide of the COVID-19 is a great reveal. It's showing everyone what our weaknesses are. And so, you know, those of you who are perhaps students or early career people, and us old people too, we need to think about how are we going to fix this? Because, you know, when people are out of work, they're out of health insurance, but that doesn't mean we don't treat them. So they're going to go to the hospital, and then who's going to pay for that? And so we really need to stop and think, you know, and I'm not suggesting universal health care, but what would that be an answer? Or would something else be an answer? And how can we help everyone have access to good care, access to clean air? You know, and so it's not just for those of us who are sitting at home. And again, I mean, I think it really shows up of who is out working so that we can sit at home. And that's what I keep talking to people about of, okay, what are we going to do in post COVID-19? How can we make a difference? And I would love to see anyone's comment. And if you want to comment, that's great. And I will answer one question while we're waiting for some comments. Is somebody made a question about what Sweden is doing which is really interesting for those of you who don't know. Sweden decided not to do the stay-at-home policy. People who are at risk, they asked them to, be protected, but everybody else was out and about. And we were like, wow, look at that. And what we've seen is their numbers are much higher than the other Nordic countries. The uniqueness about Sweden and the other Nordic countries is, first of all, they tend to be a little more homogeneous than we are. But they also, as Chris related to as governments, their policies are much more health friendly. Most people walk, their air is cleaner. They have access, everyone has access to healthier food choices. They have, everyone's there's opportunities for higher education for everyone. And so that they are more socially aware, or that's probably the wrong choice of words. They are, they think more in terms of the good for everyone instead of the good for the individual or their small group. And so they tend to be more responsive. So I thought it would have worked a little bit better, but it's turning out that their rates are going up as well. I don't know if you wanted to add anything, Chris, to that.
No, I think we were running out of time. So maybe if we opened it up for more questions.
Yes, we had a couple come in. So if you'd like to, pick any of those to answer, we can in just a few minutes. Here's a new one. Are those with blood disorders at a higher risk of infection? Article published last week states that the elevated plasmin is a common risk factor for COVID susceptibility.
Actually, while that was a published article, there are more questions than answers that it poses. A number of studies have been looking at fibrin breakdown products. A number of studies have been looking at thrombin activation, excuse me. But there's no clear evidence right now as whether this is cause and effect. So the data are just not there to support a sound evidence-based answer. The only thing we can say right now is that a weird type of coagulopathy occurs in a number of patients. We don't know what those relationships are. It's been happening in all age groups. It's been happening, again, in very healthy people as well as people who have comorbidities. So there's not a clear guidance yet as to why these coagulopathies occur, if it's truly just virus-induced, or if there's some genetic factor that might be predisposing these people to have that coagulopathy. But the clear answer is that the physicians now are putting that high on their list to look for as a patient comes into the ER with COVID-19 symptoms.
And there's a question about, and this is a hot topic, about businesses that are allowed to remain open, such as beer and mini marts, and not others, such as small businesses that do not sell food or drink, and what our thoughts are about that. Well, I'll give you my thought and then I'll let Chris answer. But certainly, I mean, as our presentation showed, economics plays a role in health. So people need an income. But we need to address this virus as well. And so my advice, and I don't know where you live, and it really does depend on where you live and how this spread is played out. So that would be the first thing, of look at that. And we really, at this point, need to follow our state guidelines. And I know it's really difficult. And Chris, I don't know if you have, and I feel for you, and I know that's not helpful either.
Yeah, I have my comments, but I think I'll keep them myself right now. There's a question here. Are those with blood disorders at a high, I'm sorry, I read that one. Can you give me the best educated guess as to how the rest of 2020 plays out? Well, I want to tie that to another question. Sharon asks, will there be a post-COVID-19 and do these diseases just disappear? And the answer is, we don't know. So we got really fortunate with SARS in that SARS did what we consider to be what's called a virus burnout. In other words, it wasn't a very good virus. A really good virus doesn't cause severe disease until it has a chance for its host to pass it to somebody else. HIV is a really good virus. SARS was a terrible virus in that regard. What we don't know right now, because it's so young in terms of its history, is whether or not COVID-19 virus will do the same thing as SARS or the same thing as HIV. It's just too soon to tell. So as a result of that, my answer to the rest of 2020 is, particularly as a public health practitioner, I see 2020 progressing as a give and take. I loved Governor Cuomo's analogy of a fire hose with a valve on it. So we turn the valve just a little bit. We let businesses come back and do what they need to do so we can preserve the economy. But if we start seeing spikes in the number of cases, we got to turn that valve back so that it's not even a trickle. We deal with it and we turn it back on, and we deal with those cases. We turn it back off. So 2020, in my mind, until we get a vaccine, is going to be this on and off to help stem the flow of cases into the hospitals, while at the same time supporting economic development. Ruth?
Thank you. Do we want to answer any of the other last questions or share poll results?
There's one last question here that I've seen. Can we comment on how bioethics and medical ethics will be shaped by the potential decisions and priorities that we're being required to make? That's a great question, Ruth, if you want to kick it off.
Wow, because there's so many ethical issues related to this, including who gets care, because fortunately many of the hospitals in the United States didn't have to do that, but they were ready to do it. So those criteria were mapped out of who got care, and then also the ethics of healthcare providers as far as PPE. Do you accept a patient when you know you can't protect yourself, or do you walk off? And as a nurse, I said I see both as leaders, right? One is going into the front and the other one is leading, saying this is not appropriate care. So I do think, I see we're very ripe for a bunch of ethical decisions, and certainly the ethical frameworks are there for us to work through them. That example of the PPE, I don't know that we'll ever have total agreement on which was the right one to do. But then also at a bigger level, what is the responsibility of our federal government and our state government? What are the ethics in that? So that's a whole course in itself. I don't mean that to be funny. I really mean it needs to be tackled and addressed.
Right.
So thanks for bringing that up. I think that's a really big issue.
So another question here is there a difference, I'm going to paraphrase and rephrase a little bit, is there a difference in the infectivity between this virus, MERS, and SARS? And right now, we don't know the answer to that. As I pointed out earlier, the variable that we look at is called capital R and the lower Greek letter naught. And so R naught is the number of people that get infected from one person who's got the virus. And we don't know what that is for this new virus yet. It's been guesstimated to be somewhere between 2.5 and 5. Well, for measles, the R naught is 16 to 18. For the common cold, the R naught is 2. So you have to start and wonder, until we get real solid testing running and testing a lot of people, we're not going to have any clue what the real R naught is. Now, to come at it from the other side, MERS and SARS, again, because they were short-lived, well, MERS is still ongoing, but SARS was short-lived. It was burnt out in 9 months. But we kind of guesstimated its R naught was fairly high, somewhere around 6 or 7. And so, yeah, it was very infectious. How is that related to MERS and this new virus? Again, the data are still not there for us to make an absolute statement about it. There's a question, Ruth, about somebody who lives close to Villanova.
Yeah, I saw that. And it was what we think the risk of rate of infection increasing as our governor opens up the various counties of the state. And it's just as Chris said, we will see more infections. And so we need to do it very carefully and then back up and kind of keep going with the Governor Cuomo example, I think is a really good one. And then the second part of that is, do I think hospitals, what do I think they'll do regarding visitors entering? I don't work in the hospitals, and I think, I mean, I know that now in the Philadelphia area, they have allowed, they're starting to allow surgeries, you know, that they delayed because of COVID-19, so elective surgeries. And so I don't really know what they're thinking as far as visitors. We still, you know, it's still going to be out there. And so we still need to protect the patient populations and the staff. So that's something that we just need to keep an eye on.
So I see as a last question, what our personal thoughts are about a vaccine. You want to go first, or you want me to keep it?
Well, I will take it, and then you can, because I know this is more your area than mine. We need one, and we need it as soon as possible, but it needs to be safe. And so we need to be patient.
So I'm extremely energized by reading about, maybe 3 or 4 vaccine producing companies that are exploring out-of-the-box ideas for coming up with a new vaccine strategy. And some of those have been talked about, are in textbooks being done in the literature as, you know, experimentally, but never on a large scale where you need tens and thousands of millions of doses. And so I'm excited about the possibility of us learning how to do a better job with vaccinology. I'm excited that what we learn here can be carried over to regular flu for a new flu vaccine, that we only need 1 shot forever. And I'm excited about the possibility that there are finally pharmaceutical companies stepping up to the plate and saying, we're going to do this whether or not we earn $1 million. So that humanitarian effort that I've not seen, and quite frankly, and I worked in the pharmaceutical business for a couple years, I've not seen that in quite a long time. And for them to step up to the plate and say, we're going to do this for the betterment of humankind, really does my heart good. So I'm hopeful that we're going to see a vaccine produced by the end of this year, and then mass production and distribution by the middle of next year.
Thank you. I'll just briefly share the poll results so you can elaborate on those couple questions you had.
Okay, so mostly alumni and faculty. The students are out enjoying themselves, good for them. And mostly people outside of public health and sciences and healthcare, which great.
Not eat egg salad or vegetables, wow.
Right. And I'm going to just slide frequently wash your hands. Okay, so they got the questions right as well, as far as frequently washing their hands, wear a mask in public, and at least 6 feet away. So thank you.
Thank you both very much. I just wanted to remind everyone that when you leave the webinar today, a survey link will appear on your screen. So please take that so we can improve on our webinars. Thank you both again, and have a great day.
Thank you.
Thank you.
Summer.
Stay safe.
Be well.